Assalamu alaikum, good morning. So today we're going to discuss systemic bacterial infections, and by the end of my discussion, you should be able to discuss the epidemiology, microbiology, transmission, pathogenesis, clinical features, and diseases associated with Brucella species and Yersinia pestis. You should also be able to discuss the treatment and prevention. So we're going to start off with Brucella species. The disease condition that results from infection with this agent is brucellosis, and it's one of the world's most common zoonotic infections, particularly in poor rural settings. Most cases in North Europe or North America are usually due to acquired infection from overseas, and if you take a very good history, the patient probably will tell you that I've been drinking unpasteurized milk or unpasteurized milk products. I've been consuming all pasteurized milk products in these countries during my travel. So this demonstrates the importance of good travel history in a patient. It is considered a bioterrorism agent because it's a biosafety level 3 organism, okay? It can easily spread by aerosols, so it represents a significant health hazard in microlaboratories. So as stated earlier, brucellosis is an example of a zoonotic infection, but it has a systemic dispersion or dispensation, so it can involve various organs and tissues of the body. The disease tends to relapse and it can become chronic, although rarely. And Brucella species are considered as Class B bioterrorism agents, and that's due to the fact that it's so easy to inhale these agents and it's easy for them to cause infection. The organism has a worldwide distribution. Anywhere where you have livestock and humans interacting, Brucella may be present. They are highly infectious and they stain poorly. They are gram-negative cocobacilli. As you can see here, this is what you would normally see under the ×100 microscope, but at a higher magnification, you can appreciate the fact that these organisms are way in between a rod and a coccus, sorry. So you can see that they don't look roundish and they don't look long enough to be described as being bacilli. The disease is also referred to as undulant fever because of the pattern of fever that the patient presents with. It's low grade, but it goes on and on and on. Okay, it goes up, it comes down, it goes on, just like an undulating structure. Okay, so it's also referred to as undulant fever. It's also referred to as Mediterranean fever because it's quite common there, it's endemic, or Malta fever. In Saudi Arabia, if you diagnose the patient with brucellosis, you must report to the Ministry of Health. It's a reportable or a notifiable disease. Now, there are many species of these organisms, but the most virulent strains are Brucella melitensis and Brucella suis. These two are the most virulent. Other strains such as abortus are associated with cattle, melitensis usually with smaller livestock, sheep, goats. Brucella suis is from pigs, Brucella canis from dogs. Now the last strain is not, strictly speaking, a zoonotic infection. Okay? It's a newly described strain of Brucella found to cause infection in women who have undergone breast augmentation. So when you have infection in a female patient who has undergone plastic surgery for breast enhancement, you should include this agent on your list of differentials. Okay? Now, the global annual incidence is not well known, and that's due to variation and inadequate surveillance systems between countries. You find out that the endemic countries for this livestock infection are the ones that have poor surveillance systems. Most of what we know is because of people who contacted infection in these endemic areas and then they traveled back to their high-income countries. Then the diagnosis was made, okay? The working rule is that it exceeds about 10 in a 100,000 person population. The major endemic areas include Mediterranean, so you can understand why it's also referred to as Mediterranean fever, the Arabian Gulf, Central Asia, and parts of Central and South America. Endemic disease is most common in countries that do not have domestic animal vaccination programs. So where you have weak government livestock policies, the infection tends to be endemic in this region. So that includes countries in Latin America, countries in Africa, the Mediterranean basin, the Middle East, and parts of Asia. In resource-poor settings, the disease is common among the rural poor for a lot of reasons. The rural poor are the ones that are likely to have intense interaction with livestock and humans. They are likely going to keep them as domestic livestock. So the animals are always present in their living apartments, which may be huts. Okay? These animals may stray into their kitchen, okay, because it's a free range livestock husbandry that they are practicing. And these are people that are cut off from hospitals. So even when infection occurs, they don't have enough healthcare intervention to manage the condition. So it tends to be endemic. As stated earlier, Brucella menintensis is the most virulent out of all the species. It's the most common species that infects humans, although studies have suggested that up to 73% of the cases in certain areas of the US may be associated with the strain associated with cows and cattle. So this table shows you a list of Brucella species associated with human infection and the usual animal reservoir, okay? So what are the risk factors? So since this is an organism associated with livestock, it makes sense that you must be in contact with, or you must come into contact with livestock to get infection, right? As you're sitting here in the room, you cannot be exposed to brucellosis unless you're sitting next to someone who's infected. You get the point. So it's more of an occupational hazard. So who are the people at risk? Shepherds, because they're the ones tending to the livestock. Abattoir workers, that is people who work in the slaughterhouse. They come into contact with body fluids from these livestock animals during slaughter. Veterinarians, doctors who take care of livestock. So they take deliveries, they treat infections, so they are exposed, particularly if they don't don on the appropriate personal protective equipment while attending to sick animals. Dairy industry professionals, because unpasteurized milk is a vehicle of transmission. So working in the dairy industry without appropriate PPE can put an individual at risk. And then laboratory personnel, working with this organism, it's a biosafety level 3 organism. It should not be handled on the open bench. The lab worker should be in a dedicated room with at least a type 2B safety cabinet. That means that the air that surrounds your work surface is not released to the general environment without filtration. So you always have helper filters that will filter the exhaust air. Is that clear? And then the patient must, the lab worker must don on appropriate PPE, which includes safety goggles or face shield, a face mask, okay? And you don't wear this type of lab coat. You must have one with a sealed sleeve. And then you may need to wear double gloves, depending on what procedures you'll be carrying out. And your lab coat must be discarded before you step out of the lab. So you don't walk around in your coat after handling the specimen, okay? So it's a biosafety level 3 organism rather. So how is infection acquired? For most people, infection is acquired through the consumption of infected, unpasteurized animal products, particularly milk. Now, this is very important because if you have undulant fever in a return patient, a patient who just returned from travel to any of these endemic areas, brucellosis should be part of your differentials. Okay? Remember that fever in a return traveler, malaria is top on my list. But the pattern of fever is different. So you've ruled out malaria. So you're now looking at the incubation period and the nature of the fever. So your travel history, you ask about the food history. It's very important. Other means by which infection may be acquired include contact with skin or mucous membrane. This is particularly important in veterinarians. Okay? You know, at times we have minor abrasions of the skin. We are not aware that we have these abrasions, but the organism uses these minor abrasion sites as a portal of entry. So contact, particularly when you don't wear the PPEs, contact with contaminated body fluid can transmit infection. Or you were not wearing the face shield and you have splashes of contaminated body fluid. Infection can still be acquired through this way. Contact with infected animal fluids such as blood, urine, or milk. Inhalation. This is particularly important in lab workers because when you manipulate body fluid, you can generate aerosols, and at the end of the day, you can inhale this agent. Now, this picture shows you the different hosts and the species of Brucella associated with them. So with goats, with sheep, you have Brucella melitensis, which is the most virulent out of all the species. And it can be transmitted through milk, where you have blood splashes during slaughter, or when you have vet doctors taking care of sick animals. Brucella abortus is associated with cows. We can also have laboratory transmission of these different species. But Brucella suis is associated with pigs and Brucella canis with dogs. There are rare instances in which you can have human-to-human transmission. You know, we said it's zoonotic, so it should have been animal to humans. But there are instances in which you have human-to-human transmission. Maybe when you have a blood transfusion, particularly on screened blood, and in situations where you have tissue transplantation. So when we talk of infections in transplant recipients, Brucella should be on your list. And rabies is another agent that you should consider. There was recently in the news a man who received a renal transplant from a patient who had rabies, but it was not diagnosed in the donor specimen. So the recipient developed rabies and died from the complications. So when we talk of rare instances, it's rare, but you should keep it in mind, particularly if you're dealing with a specific population, patient population. So what is the pathogenesis like? The incubation period is usually a range of 10 to 30 days, although you may have infection persisting for months. I'll continue to stress this. Melitensis and Suis are the most virulent, so they tend to cause more severe disease than the other two. So what will alert you? Because when a patient with brucellosis presents, they present with non-specific symptoms. You don't have signs and symptoms that will say, this is what I'm dealing with. The signs and symptoms are saying, I'm dealing with what? What am I dealing with? So your history is your best bet, because it's going to guide your suspicion, it's going to guide the laboratory investigation you're going to request for. If you're not thinking of the condition, you're not going to send samples to the lab for investigation. Exactly. So your history is very important. What is the occupational history? What do you do? I'm a vet doctor, okay? And I'm in the habit of using my bare hands to deliver pregnant animals. So that is telling me something. You understand? I traveled to one of the endemic countries, and because I was with family and friends, I did what they did. I was drinking unpasteurized milk. Telling me that means something. You understand? So your history is very important. So after the organism is ingested, now it localizes in various parts of the reticuloendothelial system. That's why it's a systemic bacterial infection, okay? And within this reticuloendothelial system, depending on what is happening, you can have formation of abscesses or granulomatous lesions. So what happens? The organism is usually phagocytosed by neutrophils, by macrophages, okay? But the organism is smart. It prevents the fusion of the phagosome with the lysosome. So instead of the macrophages killing the organism, the macrophages end up as being the safe haven in which they are going to replicate and they are going to be disseminated through the system. Is that clear? So that's why it's a systemic infection. So you can have spread to spleen, liver, lymph nodes, and the bone, and then you have the infective process well established. Patients become symptomatic. Now the organism, its ability to survive within the immune cells may cause a relapse of an acute disease, or a chronic syndrome may develop that is associated with continued illness and vague symptoms of malaria, low-grade fever, lassitude, insomnia, irritability, and joint pain. So such chronic brucellosis may follow an acute attack, or it may develop insidiously. Now the key word here is insidiously. So with brucellosis, you can have something that is building up gradually. So the patient may give you a history of, well, I've not been feeling fine, but it's not as if I've been acutely ill. I don't know if you understand what I'm trying to say. I still manage to do my daily activities. It's just that I don't feel like my usual self. You get a history like that. So when the patient comes like that, that's when you start asking, what do you do? What have you been doing? Did you travel? Things like that. Is that clear? So clinical presentation, the symptoms, like I said, they're non-specific. They may be flu-like. So fatigue, I feel tired. That is non-specific. Fever, but the nature of the fever is important. When the patient tells you, well, the fever comes on and off, but it's never high fever, okay? I just know that when I feel a little bit feverish, and then I feel like I'm normal again, then I feel like I'm feverish again. So that's an undulating pattern. Do you understand? Sweating, weight loss. Now those two conditions, they are also similar to a patient with pulmonary TB. Drenching night sweats, okay? Weight loss in the preceding months, unintentional. So in endemic areas, Brucellosis and pulmonary TB, you cannot differentiate between them based on the clinical signs alone or the symptoms alone. So your history is very important. Unfortunately, you know that tuberculous bovis can also be consumed in unpasteurized milk. So when I take the history and it is positive for unpasteurized milk, it's not only Brucella that I should worry about. I should also think of mycobacterial species. Are you following? Then you can have joint pains, muscle pain, muscle aches. So all these are in the presence of occupational history, in the presence of consumption of unpasteurized milk, Brucella, Mycobacterium TB, they are coming up on my list as strong differentials. Are you following? Then on physical examination, hepatosplenomegaly, lymphadenopathy. Now, depending on the strain you're dealing with, you tend to have, when you examine the patients, you take biopsies, you can find granulomas, or you can detect the presence of abscesses. And this condition is eventually fatal. If untreated, there are complications that could be life-threatening. So how do you make a diagnosis? There's a clinical approach. Like I said, you suspect it. And there are certain things that must be present in the patient for you to suspect. The relevant signs and symptoms, the nature of the fever. It's not high-grade fever. So there's drenching night sweat, there's undulating fever, there is muscle ache, there is joint pain. And the patient told me that, well, I've been drinking unpasteurized milk. I will think of brucellosis, I will think of tuberculosis. Are you following? But what will make me put my brucellosis on top? Consumption of unpasteurized dairy products, exposure to animals in endemic area, or occupational exposure. But you know that clinically I cannot differentiate between brucellosis and TB. So if I want a definitive diagnosis, then I have to send samples to the lab to back up my suspicion. So serology can help. When you demonstrate increasing titer against the organism, that is, you have the acute serum, the convalescent serum, and you can demonstrate that you have an increase in the titer, antibody titer, that is diagnostic. Culture of the organism. Now, this is one situation in which you have to inform the lab. I'm thinking of brucellosis, I'm thinking of TB. Both organisms are biosafety level 3 organisms. So the lab knows that this is one sample that shouldn't be handled on the open bench. So you have to send this sample to a biosafety level 3 lab. And remember what I told you that you have to do in terms of PPE and where you handle the sample. So culture, if you don't remember anything, culture should not be attempted in the routine lab. You must remember that. Everybody is going to be at risk if you do that. You can also make a presumptive diagnosis in which you collect the serum sample, but you're collecting just one sample, so you don't have acute and convalescent sample. And you do the antibody titer, and you have a value of about 1 in 160 or greater than this. Or you perform your ELISA, and it's positive, then, and it's after the onset of symptoms, then you can think more of brucellosis than TB. Now, detection of Brucella DNA in clinical specimens by PCR, this usually doesn't occur in endemic countries, because remember, these are low to middle income countries where you don't have enough robust laboratory support. Usually, this occurs in patients who have returned back to their high income countries, and samples were collected and then are saved there. So we talk of presumptive diagnosis, we talk of definitive diagnosis, and we talk of clinical diagnosis, which is more of a suspicion than a diagnosis. So how do you treat? Antibiotics are indicated, usually doxycycline combined with rifampin for weeks. Okay. In pregnant women with brucellosis, we don't use doxycycline. We use trimethoprim, sulfamethoxazole for pregnant women and children younger than 8. So how can you prevent infection? Remember how infection can be transmitted. If you don't have sick animals, you won't have brucellosis in humans. So eradication of the disease in the animal reservoir through vaccination programs. And unfortunately, in the low to middle income countries, you don't have effective livestock vaccination programs, okay? Another thing you can do is a surveillance through serological monitoring of animals for evidence of disease. And like I said, the countries that are endemic are the ones that don't carry out this surveillance program because you don't have enough government commitment to drive this surveillance program. Pasteurization of dairy products is very important in prevention. And then the use of proper safety techniques in clinical laboratories that work with this organism is also imperative. So these are prevention strategies that can prevent infection. So it's safe to say that with brucellosis, prevention is better than cure. It's better not to expose the individual to infection than to start treating the infection, okay? So we move on to the next agent, and that's Yersinia pestis. Within the genus Yersinia, we have at least 3 organisms that are commonly associated with human infection. You have Yersinia pestis, which causes the systemic infection, which is referred to as plague or the Black Death. And then you have Yersinia pseudotuberculosis and Yersinia enterocolitica. We are not going to discuss these two because they tend to cause a relatively localized infection within the GI. But Yersinia pestis can become a systemic infection. In terms of the microbiology, they are gram-negative coccobacilli, just like Brucella species. They are facultative anaerobes, non-motile, and non-spore formers. Now, they are regarded as members of Enterobacterialis. But let me sound a note of caution. You know, with E. coli, with Proteus, we say that they are commensal organisms in the gut. If we isolate them in a clinical specimen, we need a clinical context to interpret that result, okay? Is the clinical sample urine, is it CSF from a neonate and things like that? Because we know that E. coli can be a benign organism in the gut. However, with Yersinia pestis, if you isolate it from any clinical specimen, it is never considered a normal microbiota. It is pathogenic, always pathogenic, exactly. It has a worldwide occurrence. Majority of cases are from Africa. Most prevalent cases are from Democratic Republic of Congo. You know, this is a high conflict area. So you have a lot of refugee situations. So, you know, with refugee camps, all sorts of, environmental problems arise. You know, waste management is poor, water supply is poor, you don't have adequate housing, people are sleeping in tents, so they are more exposed to rodents than if you have normal civilization with no wars, no conflicts. You understand what I'm trying to say? So conflict, can drive the prevalence of this organism, transmission of this organism in affected areas. Madagascar is another area, and Peru. So what is transmission like? I want you to look at this diagram and to pay attention to the arrows. The solid arrows shows the usual mode of transmission, okay? Then you have the broken arrows with relatively long short lines. As occasional, it can occur occasionally. So here, I'll explain this later, but I want you to pay attention to the arrows. And then you have the dots, which represents rare or just theoretical, okay? So what do we have? We have the sylvatic cycle and the urban cycle. The sylvatic means that you have the wild rodents in non-built-up areas, so like in wooded areas, like in the bush, okay? So what happens is that an infected wild rodent is fed upon by the arthropod vector, which is a flea in this case. It feeds on blood. After feeding on blood that contains Yersinia pestis, the organism does something to the feeding tube of the flea so that it blocks it. So the flea is very hungry because the food is not getting to the stomach, okay? And it tries to feed on another wild rodent. And in the process, it's going to regurgitate whatever it had fed on earlier, because it doesn't want the blood to coagulate. And then it's like, I must take blood, but the blood is not getting to where it should get to. So it feeds on actively, and in the process, it's going to introduce the bacterial agent into the new host. The new host is infected. If another flea comes into contact, the entire cycle is repeated. Okay, so that's the usual thing, the solid line. Then you have the dots. This shows that at times, when you have infected wild rodents, in their droppings, in their urine, they can shed the bacterial agent. So this, when the other uninfected rodent comes along, may contaminate the grazing site or the feeding site. So, theoretically, they can pick up the organism. In domestic rodents, it tends to be similar to what I just described for the wild rodent. However, this time around, you can have direct contact, theoretically, between an infected domestic or urban rodent with an uninfected one, and then you can have transmission of the organism. Now, irrespective of how the rodent got the infection, humans can become incidental or accidental hosts. And how may this happen? Various ways. If you are a lumberjack and you're going into wooded areas where you have infected wild rodents, it's possible to come into contact with their droppings, their urine, or even the organisms themselves, the animals themselves. So you can have a direct contact, leading to the transmission of the bacterial agents. Now, in this situation, most of the time, you tend to have inoculation maybe through the skin, okay? So, drainage is going to be to the lymph nodes. So these lymph nodes may be in the groin, in the axilla, or in the cervical region. Now, these lymph nodes, once they are invaded by this microorganism, they swell up, okay? They become painful, and with time, they form abscess. So the abscess is referred to as the boo-boo. So the lymph node that becomes fluctuant is what is referred to as the boo-boo. So we talk of bubonic plague. Is that clear? When the lymph nodes are infected. So we talk of bubonic plague. Now, this individual who is infected, remember, this is a dotted line, so theoretically, when this person breathes out, you can have the organism in the aerosols, so you can have another human host secondarily exposed to the human. So this person is not coming into contact with the rat, or the flea. Are you following? But an infected individual theoretically can, send it. So we say it's a secondary pneumonic because now the lungs are the main organ affected. Are you following? So that is one. Another way by which infection may be transmitted is when we come into contact with the fleas that are infected. So a flea bite can also transmit infection to humans, and you may have the bubonic plague. You can also have direct contact with infected domestic rodents, okay, or fleas that have fed on infected domestic rodents. All these are ways by which humans can become incidental hosts. Is that clear? Now, when you have pneumonic plague, then it can become a person-to-person transmission situation. Remember that both brucellosis and Yersinia pestis infection are zoonotic infections. So usually it should be from animals to humans, right? But with bubonic, pneumonic plague, once an individual is infected, you have involvement of the lungs, they can become a source of infection to others. So you can now have human-to-human transmission. Is that clear? The incubation period is about 1 to 3 days when you're dealing with infection involving the lungs, that's the pneumonic plague, or it can be 2 to 6 days when you're dealing with lymph node involvement, that's the bubonic plague. It's important to know that it's zoonotic, so the primary host is the rodent. Okay, it could be the wild rodent, it could be the domestic rodent. But humans get infected when we come into contact with the rodent or we are bitten by an infected flea. Most of the organisms are phagocytosed and killed by the polymorphonuclear cells in human hosts. However, with tissue macrophages, when they pick up these organisms, they can't kill the organism. So within the macrophages, the organism behaves like what we described for the Brucella organism. So they are going to thrive. But they go a step further. With Brucella, it's just that you have prevention of phagosome and fusion with lysosomes, and that's it. But with the Yersinia pestis organism, within the macrophages, they start to elaborate virulence factors, such as lipopolysaccharide capsules, things that will further enhance their ability to evade the immune response. Okay? So what happens? Eventually, they kill the macrophages off, okay? And they are released from within the intracellular to the extracellular environment. And because you now have this group of organisms that are being released from the macrophages, remember, they have now started to deploy virulence genes and their gene products. So they are able to resist phagocytosis by polymorphs. So it becomes a self-perpetuating infection. So you can have swelling, and I want you to look at the surrounding areas of this lymph node. You can see that it is hyperemic. That shows you that there is intense inflammation. It's painful, and if you can feel this lymph node, it's going to be fluctuant because you have purulent collection in the lymph node. So this is what we refer to as a bubu. Now, within hours of the initial flea bite, infection can spill into the bloodstream. So you can have a septicemic presentation where you have the organism present in bloodstream, and when they are not just innocently present in the bloodstream, they can trigger off dysregulated clotting, DIC. Okay, so you can have disseminated intravascular coagulation. Okay, so you can have them being unduly susceptible to bleeding. You can have necrosis. of organs that are supplied by vessels that are affected. You can also have the patient developing severe bacterial pneumonia, and in the process they exhale large number of viable organisms into the air during coughing. Now, this is a highly lethal condition. About 50 to 60% of patients, when untreated, will eventually expire. So, how does the patient present? 3 classical presentations. You have the bubonic plague, where you have involvement of the lymph nodes, septicemic plague, where you have a bloodstream dissemination, okay, and you can have pneumonic plague, in which the primary organ of involvement is the lung. Other modes of presentation. This is the fever associated with plague is different from what you have with brucellosis. Remember, we said with brucellosis it's low grade and it's undulant and things like that. With Yersinia pestis, there's high grade fever, so the fever is quite, it's something that the patient will complain about. There's malaria, okay? You can have shock. Remember, patient can have DIC. Patient can have convulsion. Then you can have diffuse hemorrhagic changes in the skin with cyanosis. Remember that when the lungs are involved, the process of oxygenation is compromised, so the patient has central cyanosis. And coupled with the bleeding in the skin that tends to affect the extremities, you have these black lesions, and that's where the name of the disease arose from, the Black Death, because by the time the patient is showing up like this, the patient is close to dying, okay? So how do you make a diagnosis? Again, clinically, there are certain things that will point you in that direction. A patient who is febrile, high-grade fever, okay? It's not malaria. You've sent in your blood sample for malaria parasites. It's negative. But they told you that they've been exposed to rodents in a known endemic area. So, they've traveled to maybe on outreach programs, maybe as a result of occupational requirements, they've traveled to these endemic areas. So you have to start thinking of plague. And it's important you think of it early, because remember, this is a BSL-3 organism. You have to isolate this patient from other patients. You have to protect yourself, because if the patient has the pneumonic plague, you are at risk as well. Okay? You know what is going on with the hantavirus in the news now. So at times when we discuss these things, don't think that it's just for the books. It's real life. You have to start thinking of the worst before you think of the benign conditions. That way you keep yourself protected. Okay. Now, rapid recognition of the condition and collection of appropriate clinical samples sent to the laboratory for confirmation are essential to institute life-saving therapy. I'll stress the fact that this is a BSL-3 organism. You have to start thinking of the worst so that you can protect yourself. Remember that the doctor on the cruise ship is down with infection now. They are not so sure whether it's the hantavirus or not. But that was because the initial patient, a 70-year-old man, some said 80-year-old, that was patient 0. They just thought it was maybe GI upset and things like that. So they were not really taking in the adequate precautions. If that doctor had thought of the worst, not necessarily hantavirus, but think of something deadly, so you can protect yourself and protect others, this would not have happened. The wife got on a plane. It was when she fainted at disembarking that they now started worrying what's going on. One of the air hostesses on that flight came down with signs and symptoms. They're not sure if it is hantavirus or not. And then you allowed people to disembark from the ship and to go back to their home countries. So what is going on here? And, another thing about the hantavirus, I think we'll discuss this in the lecture on systemic viral infection. The site of origin of that strip, Argentina, is known to have the Andes strain of the hantavirus, which is so far reported to be the only strain that is transmitted from human to human. The other strains are zoonotic. So that ship took off from a site that is known to have that strain of the virus, and everybody is comfortable going all over the place. I mean, it's sad that it happened that way. Really, it is, because it's like we've learned nothing from COVID-19. Well, the WHO says no, but then they told us the same thing about COVID-19. You know the problem with RNA viruses? They mutate a lot. So my fear is, what are we dealing with now? Because we've had more hosts for amplification and probable mutations. So we may say, well, it has a low RO value, that's what they're saying. But my question is, what is going on with the virus inside the different hosts? Right? So it's like we didn't learn anything from the COVID-19 era. But we'll see how it goes. But it's sad. I know that going on a cruise ship is out of my bucket list. That much I know. I'm not going to try it. Unless I'm going to go in an hazmat suit. But it's nothing I'm going to think of again. Yeah, it was on my bucket list, but now I'm thinking seriously that maybe it's not a good idea, okay? Anyway, I digress. Back to the story. What specimens can you send to the lab? It depends on how your patient presents to you. Remember, you can have different clinical presentations. So if you have the septicemic plague, blood can be sent for culture, but remember, you have to alert the lab. Don't send it in as a regular blood culture specimen. Lymph node aspirates can be sent to the lab. We can perform a smear or we can culture it. Now, if we perform a smear, this is not from a lymph node aspirate, this is from blood, as you can see the red cells. But the organism has a characteristic staining pattern. It has that safety pin appearance. So if we perform a smear on the clinical specimen and we can identify this organism, then it's plague until proven otherwise. Okay? You can also send in samples for serology. We can assess the antibody level, but you need a paired serum sample, so acute and convalescent serum. In patients who have the chest infection, sputum can help to make a diagnosis. Where you suspect meningitis, cerebrospinal fluid can also assist in making a diagnosis. We tend to use the Wesson stain to prepare these smears in this case. In terms of treatment and prevention, again, we need antibiotics, usually the aminoglycosides. You should know that beta-lactams are not effective if you're thinking of plague. Now, doxycycline is one of the agents that can be used for post-exposure prophylaxis. So I have an old garage, I cleaned it out, I now notice a lot of droppings, rodent droppings, and it's poorly ventilated. So I'm worried because I'm aware that I can acquire infection through inhalation. So I come to the hospital, I report myself. This is what I've done, okay? And this is the drug that you should recommend. How can you prevent infection? Now, with patients with pneumonic plague, you already have the imaging studies, you have the signs, you have the symptoms. you should put them in isolation and you should institute airborne precautions because you don't want an outbreak on your hand. Now, if the environment is clean, waste management is top-notch, you're not going to have a lot of domestic rats in the environment that will find their way into your kitchen or into your homes and things like that. So eliminate urban plague with sanitation measures. Remember, if you're thinking of this agent, when you send sample to the lab, you must indicate. Because if you don't, and it is handled as a routine clinical specimen, you have most of the lab staff coming down with infection. Unfortunately, we don't have vaccines. Just like with Brucella, there are no human vaccines. So these two conditions are better prevented than treated. Is that clear? So prevention is better than cure in these situations. And that's it. Any questions? Okay. So enjoy the rest of your day.